Hello, I'm Christopher Ritchlin from the University of Rochester Medical Center in Rochester, New York. And I would like to present to you the EULAR poster from the 2021 meeting entitled Proteomics Analysis Comparing the Mode of Action of upadacitinib between non-biologic DMARD inadequate responders and biologic DMARD inadequate responders. PSA patients identify as distinct pathogenic pathways in the SELECT PSA-1 and SELECT PSA-2 phase 3 studies. Treatment of non-biologic DMARD inadequate responders, or DMARD-IR, and biologic DMARD IR2 or bio-IR PSA patients with UPA 15 milligrams a day, an oral JAK1 selective inhibitor, result in significant improvement in signs and symptoms of PSA compared to placebo. The objective of this abstract was to explore immunological pathway modulation by UPA 15 milligrams a day in PSA patients with active disease despite treatment with non-biologic or biologic DMARDs in the context of clinical response versus non-response to treatment. In figure 1, we see that treatment with UPA 15 milligrams a day resulted in a down modulation of protein biomarkers associated with T cells, myeloid cells, and interferon, IL-5, and TNF-related pathways, similarly in DMARD-IR and bio-IR PSA patients. Figure 2 shows DMARD-IR patients' response to UPA 15 milligrams a day, defined as a PASDAS of less than 3.2, at week 12 was associated with greater inhibition of IL-1A, IL-6, IL-10, and TNF-SF10, while in the bio-IR patients, response was associated with greater inhibition of CCL2, IL-17A, IL-24, and MMP10. In addition, response to UPA 15 milligrams daily, defined as achieving PASI 75 at week 12, was associated in DMARD-IR patients with greater inhibition of CXCL9, IL-5, IL-24, and TNF-SF10, while in the bio-IR patients, PASI 75 response was associated with greater inhibition of IL-17A and MMP10. Figure 3 shows in silico prediction of upstream pathways modulated by treatment with UPA indicates that in DMARD-IR patients, clinical response was associated with a down modulation of protein biomarkers predicted to be linked to interferon beta, CD40, IL-10, and IL-17 pathways, while in bio-IR patients, clinical response was associated with a down modulation of multiple protein biomarkers predicted to be linked to the IL-17, IL-23, and IL-1 pathways. In conclusion, the effects of UPA in both DMARD-IR and bio-IR PSA patients likely stem from the direct and indirect inhibition of multiple biologic pathways belonging to the adaptive and the innate immune system. Responder-non-responder analysis suggests a possible shift from a Th1-based biology in DMARD-IR PSA patients to a more Th17-based biology in bio-IR PSA patients. These findings highlight the importance of targeting multiple pathways with drugs such as UPA, which are effective in both DMARD-IR and bio-IR PSA patients. Thank you for your attention.